let me move to my talk. Heart failure is a global, an estimate 64.3 million heart failure worldwide, and in China is 4.5 million. So ischemic cardiomyopathy is the most common cause of heart failure, and if treated by medical therapy, very low survival. So it's a really challenge for all of us, and also many guidelines is very helpful to guide the patient treatment strategy. However, for the individual patient, it's really challenge. How to identify patients who could benefit from revascularization is very important. Nuclear cardiology have two major advantages to identification, myocardial ischemia, and hypertension myocardium has very important value to identify patients who could benefit from revascularization. Also, many multiple parameters could get the SPECT study and get the PET. We can get the regional and global function, and also we can have the phase analysis, and the left ventricular synchrony also can be analyzed. So many parameters by one procedure we can get. It is well known. Myocardial viability study was advocated firstly by Dr. Sherbert group and UCLA. And I'm very lucky when I'm a PhD student and Dr. Sherbert have a lecture in my hospital at the international meeting. So then I worked with him at UCLA in 2003 and 2007. Then also I started the cardiac PET in China in 1997. That's the image at that time. That's the PET system, the 4 rings. The image quality not very well, but for the visual analysis is no problem. So after that, and our study is become the routine clinical practice, have many important value in the clinic. However, how to get a high quality cardiac PET image is still real challenge. It's a cost time, and also the patients with severe heart failure. We need to really be careful for the patient safety. At that time, we couldn't use gated study, so we use echo to measure the ejection fraction and also measure the left ventricular diastolic volume. We can see the ejection fraction gradually improved, and left ventricular remodeling was gradually reversed. So demonstrated the viable myocardium is correct. That's one case. It's not a very good, resolution is on the rail, but patients with a large amount of viable myocardium after surgery ejection fraction was much improved. We also know the hypertension myocardium is a progressive deterioration, and the cardiomyopathy was gradually lost and replaced by fibrosis. And for the nuclear cardiology technology, we can dynamic imaging to analyze the changes. So how long time the hypertension myocardium could be survived? It's a difficult question because a lot of information was affected. And let's see one case, 74 years old, 3 vessel disease, large amount of, this is a RAS study, FDG PET study, large amount of viable myocardium in this case, but the patient rejected to be treated by surgery. So 1 year later, and follow-up PET study, and we can see, we look at the image in septal wall. The perfusion, no difference. However, for the metabolism, it's much significantly decreased. Large amount of viable myocardium in septal wall, but right now become the scar, and the EDV was enlarged. and 2 years later, the patient suffered from cardiac death. And in our study, the hibernation myocardium has important prognostic value. From the early study, that is 2001 published, and the patient with viable myocardium treated by medical therapy have a higher cardiac event and cardiac death. And the result was consistent with the meta-analysis reported by Allman. And in 2002, I started to focus myocardial viability in patients with left ventricular aneurysm, because in routine clinical practice, more than 30% of patients have a viable have aneurysm. So I want to look at what kind of these patients' prognosis. And we found if patients with viable myocardium, annual mortality is a high 11.6%, which was significantly higher than patients treated by revascularization. And also, the patient with a severe heart failure, usually revascularization in comparison with medical therapy can significantly improve the survival. That in 1997, the study, and 2009 later, 10 years later, is a similar result. But we know the medical therapy had a significant big progress, improve the patients treated by medical therapy. So the 37% survival in comparison 54. And recently, because 2016, I moved another hospital. We, we have more than 3,000 patients. Ejection fraction less 35%. We look at the image for the result. Patients treated by medical therapy, 4 years survival only 33%. So it could be significantly improved by revascularization. But how to identify these kind of patients? Because the patients, it's many factors to decide the patient outcome. So we look at the imaging, the patient with viable myocardium, and 1 year survival, 79%, and 4 years, 49%, which was significantly lower than patients treated by revascularization. And the patient survival by medical therapy and with viable myocardium, which was similar with before 1997, 2009. So it's very important to how to identify these kind of patients. And we look at one case, 63 years old, cerebral disease and severe heart failure, and a large amount of viable myocardium, and ejection fraction only 90%, and large volume. And the patients treated by coronary bypass graft. And during the procedure, and the blood pressure gradually increased. And 9 days after surgery, the ejection fraction improved 42%. So it indicates the viable myocardium is correct and identified by pre-surgery. And also left ventricular remodeling, is very important for contribute to the heart failure. So how to identify the left ventricular remodeling, is have a different kind of techniques. But nuclear cardiology, we have the gated study. We can analyze this kind of information. We can do one imaging by the peak in our lab. We can dynamic imaging to analyze the changes in myocardial perfusion and the metabolism, and also ejection fraction, and also for the volume. It can be enlarged and the ejection fraction is decreased. And also the wall motion, wall thickening, the extent much enlarged. So for the animal study, we can dynamic evaluate the perfusion viability and also ejection fraction, and also the remodeling information. So we can have more information to analyze pathophysiology information. So in clinical practice, the patients usually coming to hospital is severe heart failure. So how should we combine the hibernation myocardial information and remodeling information to identify patients who could be benefit from revascularization is very important. Look at our data. If patients no hypernation, no remodeling, and remodeling we use 70 millimeter and per square meters, and the patient's outcome very good, and 98% 4 years survival. But if both positive hibernation and remodeling has a severe cardiac death. And we look at the treated by different treatment strategy, medical therapy or revascularization. If no viable myocardium and with remodeling and treated by medical therapy, have the survival is lower than revascularization, but no significant difference. However, if a patient with a viable myocardium without or with remodeling and the patient treated by revascularization could significantly improve survival. And if a patient treated by medical therapy, 42 months is a very low survival. And if both is a positive and only hibernation, 62%. So it's very important to combine the both information to guide the clinical decision, improve the patient's outcome. Let's look one case, and 60 years old male, and no ischemic stress, rest study, no ischemia, and severe heart failure, and remodeling very severe, and the PET study, no viable myocardium in LD territory. So patient treated by medical therapy and follow-up 48 months, there is no event. And also, how long time hibernation myocardium could be improved after revascularization? It's a lot of factors also. And we look at the old study, mismatch extent was a correlation with the delta ejection fraction improved. And we used the 27 patients and found the percentage of hibernation is a total peripheral defect. How much percent of hibernation among total peripheral defect? We found 55% could predict reverse remodeling, and also negative correlation between hibernation percentage and change of add diastolic volume was observed. So it means the more the hibernation among the total peripheral defect, the better could be reverse remodeling. The patient number is not big enough, but we still continue for this kind of study. And also in Angel Hospital, is the most severe heart failing patient come to visit our hospital. So the patient is very severe, and with this case and is a large amount of viable myocardium, and follow up, we can see the anterior wall, septal wall, the perfusion much improved, but inferior wall and the lateral wall not much improved. So it's 6 months. And we look at the ejection fraction, 30% improved 70%. It's not a big change, but for the reverse remodeling, EDV from 330 milliliter and decreased to 49%. And we look at the regional thickening wall motion, we can see the regional thickening in anterior wall, and it is gradually improved. It's 6 months. And look at the 9 months, and the patient, no difference, and the phase analysis is worse. So we can evaluate the outcome and evaluate the treatment effects. So it's a very important information for guide the patient to continue treatment. And also we know even hibernation myocardium is a long study and many clinical and experiment study, but the mechanism still is not very clear. And we did some study, and the ischemic cardiomyopathy, we observed the myocardial flow reserve in remote area, viable, non-viable area, and we find the patients, the regional with viable myocardial flow reserve was significantly lower than remote and also volunteer. And also in regions with viable myocardium, FDD uptake by hibernation myocardium was negatively correlated with the FDD uptake, is negatively correlated with myocardial flow reserve, and means the hibernation myocardium want to maintain the viable, so can be increased uptake, FDD uptake. So it's the result is very similar with the previous animal study. And also we know an interaction between heart failure and the disorders of the brain has been widely recognized in past decade. However, the underlying pathologic mechanism of brain dysfunction induced by heart failure is largely unknown. So the global glucose metabolism in the whole brain and in cognition-related regions in heart failure patients remains highly elusive. So we did some study, and the patients grouped by hibernation myocardium and ejection fraction, and the 5 groups. In the whole brain SUV metabolism have a significant difference among different groups. And also, if a patient with severe heart failure and the ejection fraction very low, and the whole brain SUV is significantly low than this group is significantly lower than patients volunteer. And also we did the regional SUVRS. We found in most cognition-related front areas, and the hibernation myocardium was positively correlated SUVR. And let's look at the 2 cases. One case with a large amount of viable myocardium, ejection fraction 22%, and a severe remodeling, and the whole brain imaging we look is good. But another case, and the ejection fraction 50%, and the large myocardial scar, and the metabolism was significantly decreased. So brain metabolism in the whole brain was significantly reduced, but maintained in cognition-related front areas in heart failure patients. And so it's just the primary study. We are still continue to analyze data and collect more patients. I have take a few slides to introduce my department. We have the cyclo, and we have a micropad CD, and also we have expert to for establish the animal models. So we did a lot of rat, mice, and pig study. And this is a FAPI, and this is FDTPA for inflammation, and with dynamic imaging, like pre-surgery, 1st week, 4th week, and 8 weeks. And we did, we want to evaluate the pathology